I am Pinkal Desai. I'm an associate professor of medicine at Weill Cornell Medical College. I'm in the field treating myeloid disorders, including CMML, for the last 10 years that I've been working here at Cornell. My practice is devoted to a variety of myeloid disorders. So I see spectrum, for example, in CMML, right from very early stages, what we call CMUS, or clonal monocytosis of uncertain significance, which is sort of the stage before CMML, if you might, and then it's transitioned to earlier CMML 1, 2, and also when it actually converts to acute leukemia. I am part of, so I've been involved from the beginning with the LLS's initiative, right from the CMML grants initiative to the creation and push for the for help into the CMML trials network. I've been participating in a lot of these meetings. The CMML trial initiative was initially a few institutions together, and I think now that LLS has taken an active role in expanding this, this would be very helpful, because I think one of the issues CMML patients face, and generally this field in general, is, relatively CMML is, what we call a rarer disease, but honestly, it is not that rare because the incidence is similar to some other disorders like myelofibrosis, where there are dedicated trials and approvals and big phase 3 trials happening. It's just somehow, as a disease, was sort of second to MDS, or myelodysplastic syndrome, and most trials have lumped these two together when the biology is actually different, and there was not a push for putting these patients separate and studying the diseases in separately. Because when a trial opens with MDS and these trials allow CMML in addition, more than 80% of these patients on these trials are MDS. So you really never get a signal on the few CMML patients that go onto the study. So you get an approval of a drug really for MDS, and we kind of use it potentially for CMML if it is approved. And that has been a challenge to have a dedicated CMML specific trials going on to phase 3 studies. And second is the development of a specific drug. I think that to have every institution together, to have drugs that are specific, that direct towards the biology of CMML, and at the same time, a trial being large enough that even larger institutions that see CMML patients, they're not as common as MDS, and to allow a trial that's big enough so that every institution can pool their CMML patients. I think that has been a challenge, and that's what LLS is developing in collaboration with all of these academic institutions, to try to figure out how we can move a drug quickly through its entirety of development and into phase 3 trials. What I hope happens is, as CMML directed therapies take center stage, that one, patients get to know about this, because right now I think a lot of patients are being told CMML, MDS, it's all the same, particularly in the community, so they can seek out these clinical trials that are specifically CMML related. So we hope that the outreach to patients is strong. We hope that this network and this push leads to better development of drugs that are specific to the biology of CMML, that companies and pharmaceutical industries also get interested in running trials that are specific for CMML rather than a adjunct to an MDS trial. We hope, third thing, is we can actually pull these drugs into trials that accrue rapidly. So reduce the amount of bureaucracy that goes through institutions for rare disease populations, where we are maybe enrolling 2 or 3 patients versus like 10 to 20 that a lot of these institutions are generally used to for myeloid disorders, to create a rapid network where you can finish a clinical trial rapidly rather than taking a long time, where a lot of these companies don't have funding to hold a trial for 10 years. We want the biology to develop, the drug to get into the trials, and then rapidly accrue patients. And ultimately also hope that from a standpoint of endpoints and FDA, I think FDA is already there where they would entertain a CMML specific endpoint and CMML specific trials, but now we have to prove that we can pull this off. And I hope that this network does all of it, gets in patients, gets the right drugs, and accrues trials rapidly. There are definitely CMML patients that progress rapidly. And then there are patients with CMML who, in spite of having a certain genotype that you would think would make them progress rapidly, actually are stable for a very long time. And understanding these biological differences is also important, because you want the right kind of patients to go into the right kind of trials. And trials could be divided into, when CMML is aggressive, to try to put into remission and potentially to transplant. That's one aspect. But there are trials that could be designed also to stabilize CMML, to not let it progress more. And that's where these patient selections and understanding the biology is important. And I hope that as institutions are pulling more resources into this and LLS's involvement, that we are able to distinguish who it is that is going to progress rapidly, who's going to progress late, and what kind of drugs should be targeted to either of these two populations.